Hi everyone, thanks for listening to my presentations. Today I'll be talking about hypothyroidism treatment. And that will form part 4 of 7 when it comes to series on hypothyroidism. If you haven't listened to the previous presentations, that is parts 1, 2, and 3, please kindly do. Because part 1 is all about Hashimoto thyroiditis, part 2 about symptoms and signs of hypothyroidism, part 3 about causes of hypothyroidism, diagnosis and differential diagnosis. But today, I'll be limiting myself to the treatment. Okay, let's go. The first question to ask ourselves is, who requires treatment? And the answer will be anyone with overt primary hypothyroidism, with thyroid function tests giving us a picture of increased TSH, with decreased free T4, will require treatment, with or without symptoms. So we don't have to see all the symptoms that are presented as per the symptoms and signs of hypothyroidism before we give levothyroxine. There should be no treatment even if there is increased TSH and decreased T4 in anyone having the cause of this problem associated with medication. And ask me why. All you need to do is discontinue that very medication and then watch. Things will normalize back. Typical example is amiodarone or lithium. Just discuss with the attending physician who has prescribed those medications and find another way out to help with the mood stabilization if it is lithium, or the arrhythmia if it is amiodarone. And you will see the patient might be back to normal, even with increased TSH, decreased T4 in the face of those medication administration. Once you discontinue the medication, you'll be out of it. So you don't need to be looking for levothyroxine under that situation. Okay, discuss the following scenarios with an endocrinologist to determine whether or not you are to treat or you are not to treat. Subclinical hypothyroidism. There are a lot of controversies about argument for or against treatment here. I will personally treat if I'm dealing with a child with subclinical hypothyroidism. Discuss with your endocrinologist, and of course, sometimes you can discuss with your pharmacist. The same with painless thyroiditis or subacute thyroiditis. Okay, we are now dealing with specific scenarios. We've known who to treat and who will not need our levothyroxine. Congenital hypothyroidism. Please start treatment immediately after screening as neonates. Immediately in many centers around the world, thyroid screening is part of the processes to pass through immediately after birth. Okay? Once that diagnosis is made, within the first 2 weeks of life, please start treatment. Use a very high dose levothyroxine. Okay? So the dosage of levothyroxine is inversely proportional to the age. That's the way I could put it. The younger the patient is, the higher the dosage of levothyroxine when it comes to hypothyroidism in every human being. The higher the patient is, that is, the older the patient is, the lower the dosage of levothyroxine when it comes to hypothyroidism. So go for a very high dose in neonates. You can go for about 10 to 16 micrograms per kilogram per day. That is acceptable. Meanwhile, in older adults, all you need is about 1.6 microgram per kilogram per day. So you give about 10 times the dosage you give elderly to the neonates. Once thyroid-stimulating hormone is high in children, whether they have symptoms or not, please treat. And treat until they are 2 years plus. Why? Brain development is between birth and the first 2 years of life. And we need thyroid to help achieve that. Or else, the child will come down with mental retardation, learning disability, and of course, growth failure. Thyroid function tests should be done every month until the 3rd birthday. Thereafter, you can relax to every 6 months. What's the goal of my therapy? All I want is to assuage the symptoms. Bring the suffering down, okay? Make TSH to be within normal range. It depends on the values where you're working, okay? So, might not take this for it, okay? Reduce the size of the goiter. Prevent overtreatment. Like, this is hypothyroidism, then you start loading the individual with hypothyroidism with too much levothyroxine, then you take the individual to thyrotoxicosis again. No, I don't want that. Prevent that. Remember that the older we become, the higher the value of TSH. So, in an elderly man that is about 80 years, the TSH of 7.5 milli international unit per liter is normal. Though that is slightly normal, slightly above what the normal TSH level should be, right? But in my grandpa that's 90 years, and you pick 7.5 milli international unit per liter, that is normal. We should have that at the back of our mind. Okay. Please check my channel for the definition of hypothyroidism, clinical features, diagnosis, and differential diagnosis. And then rest solely on the following, because from there you will know that T4 is levothyroxine, T3 is liothyronine, and we have Leotrice, that is combined T4 and T3. I will have to talk more on that. Okay, T4 only, you can give T4 between 12 micrograms per day up to 250 micrograms per day. But remember, the older we become, the less the dosage. Okay, warning about combined T4, T3 therapy. Please, this combination is not encouraged. It is not encouraged. Some experts will not use this, while some will do. But for the purpose of this presentation, I will always bring to you what the facts are. It is okay to use this combined therapy in the face of thyroidectomy or ablative therapy with radioiodine. But it is not okay. It is not good. We should not use this combined therapy in older patients. It's not acceptable when anyone with hypothyroidism is having underlying cardiovascular system disorder. No. Combined therapy is contraindicated in pregnant women. So you can see, you can continue your life without dabbling into this combined therapy. But that is not to say that you can't use it at all. You may use it in the face of thyroidectomy or ablative therapy with radioiodine. When you're having combination therapy, that is combination of T4 and T3, you can pause to go over what I have here for some few minutes And you may go ahead to discuss with your pharmacist or with endocrinologist. But something is clear here. The dose of T3 is not that as big as that of T4. And you can give T3 sometimes twice daily, sometimes in the morning and night time, or 3 times daily. While T4 is certain dosage per day. Pause and go through. But discuss with your pharmacist, discuss with endocrinologist. Okay, drug of choice is T4, right? Levothyroxine. But you have to give a low dose of that medication under certain situations. 1. Elderly, my grandpa, okay? Please start slow from 12.5 microgram daily. Secondly, someone with coronary artery disease, you can start from 25 microgram daily, but discuss with your pharmacist, please. But I'm pretty sure under these two situations, you cannot jab the affected individual a very high dosage from the beginning. No. High dosage is required in young people from 1.6 microgram per kilogram per day to also healthy patients from 1.6 microgram per kilogram per day, and of course children from 1.6 microgram per kilogram per day, or even higher in children. Like if you check back, you can rewind back to congenital hypothyroidism. The treatment there will be about 10 to 16 microgram per kilogram per day. So the younger we are with hypothyroidism, the higher the dosage of levothyroxine. T4 could be taken with some conditions or precautions. Take it on empty stomach. Take it 30 to 60 minutes before the breakfast. Please, no excess iodine or iodine-rich foods like kelp or seaweed. Not this time. No soya dye per oral, please. Why not? Soya milk, soya dye, soya whatever is pretty good for our health, but in anyone with hypothyroidism taking levothyroxine, there could be inhibition of absorption of levothyroxine by the soya milk or soya diet containing food. There's a separate presentation already published by me on my channel as per relationship between soya milk and T4 in gastrointestinal tract. You can check that out. Also, in somebody who is taking lithium amiodarone, watch out. The situation might not be the same. Reevaluate the patient 6 weeks after the onset of therapy. And how do we do that? Do thyroid-stimulating hormone again. Adjust dose based on the value of TSH. Assess symptoms changes and resolution in 2 to 3 weeks. Expect thyroid-stimulating hormone to stabilize in 6 weeks. If thyroid-stimulating hormone is persistently high, ascertain if the patient is truly taking the medication prescribed or not. You may increase the dose of T4 after discussing with your endocrinologist or pharmacist. It is better to remain on the same formulation. And with that, I've come to the end of this very presentation. The next presentation will be about subclinical hypothyroidism, and that will form part 5 or 7 of this series. Thanks for listening. Please remember to share this presentation and subscribe. I appreciate it.